We don't have a bio.
Okay, morning everyone. So I'm going to talk a little bit about herpes simplex hepatitis, and I'm going to start off with a case study, which comes from my registrar days. So this is from very far back, as you'll see when we get to the diagnostics. But I think it's a very nice illustration of a classic herpes simplex hepatitis. So this particular patient presented to Universitas Hospital in Bloemfontein. He was a 40-year-old male who was a farmer from Maltino, and he'd become ill about 7 days before he presented to hospital. So he had very non-specific flu-like symptoms, fever, headache, and then he specifically mentioned the severe pharyngitis. He then developed rigors and severe epigastric pain, and then progressive dyspnea, which is why he eventually presented to hospital. So he'd been seen by his GP in the area 4 days before his admission, and the GP was concerned because of those non-specific flu-like symptoms about tick-bite. So he started him on doxycycline, but there was no improvement within the first couple of days. So then he added Ciprangenta at that stage, but no blood tests or anything were done. He didn't have a specific history of a tick-bite, but he did have contact with animals, and they had been tagging their cattle. So he had contact with blood on his own hands, and being a typical farmer, he had various little scratches and things on his hands. So there was the potential for blood contact. There was nothing relevant really from his medical history. It had static cholecystitis, which I think he initially thought this may be with the abdominal pain, and he wasn't on any chronic medication. By the time he presented to us, he was acutely ill. He was tachypneic. He wasn't febrile at that stage, but his family reported that he had been febrile in the week leading up to the presentation. He was jaundiced. He didn't have obvious bleeding apart from some scrotal petechiae, and he was definitely a bleeding tendency. So when they drew blood and put up drips, that sort of leakage just didn't want to stop bleeding. But nothing else dramatic actually in terms of the clinical picture. On his admission, bloods, so chest x-ray, again, nothing dramatic, but you can see from his full blood counts, HB was slightly low, platelets of 31, normal white cell count, but lymphocytes slightly decreased, and by the time he got to us, as you can see, his kidney function had deteriorated, and liver function even worse, so he had raised beliefs, but not dramatic, given if you look at his cellular enzymes, AST and ALT, of 11,000 and nearly 5,000 respectively. So unfortunately, he passed away within about 3 hours of presenting to hospital. So we didn't have a diagnosis at that stage, but our differential, obviously, because of the farming history, this was during summer and he'd had contact with the blood. So Kumen-Congo hemorrhagic fever was sort of top of our list in terms of infection control, etc. And because of contact with the family members, obviously other viral causes of the fulminant hepatitis that I'll sort of go through, but things like Hep A and B would be top of list, herpes simplex as well. Bacterial septicemia, although he was on a range of antibiotics. Tick-bite fever certainly can present like this, but unlikely, obviously, because he'd been on doxy for 4 days already, so he should responded to that normally within sort of 24 to 48 hours, one would expect an improvement. So the results then came back, as you can see, we're still doing biophysics in that stage, which is negative, which we know now is rather useless, but there we go. There was a Corynebacterium species in blood culture that we thought was just a contaminant. His HIV, hepatitis A and B were all negative. Congo fever, which was sent off to the NICD, eventually came back as negative as well after a couple of days. But his herpes simplex IgM was positive, IgG negative, so potentially an acute infection. The problem always is that in these patients with severe hepatitis like this, you often can get false positive IgM results. So that did give us a hint of what might be happening, but that wasn't adequate in terms of making a diagnosis. So we did manage to get a post-mortem liver biopsy. They weren't willing at the time to do a full post-mortem because of the potential for Congo fever. Because we didn't have that final diagnosis yet at that stage, but the liver biopsy actually gave us answers. So there was diffuse hemorrhage, necrosis, and fatty change. So you can't see my It's obviously the white areas there are the fatty change all over. The sort of bright pink areas is all the hemorrhage. And then the sort of dark purple nuclei are the herpes type inclusions, the CalGA bodies. So this was a herpes simplex hepatitis. We didn't have PCR available at that stage, which tells you how old this is. But what we did have is cell culture. So just for historical interest, we put a serum onto cell lines, and this is an example. So on the left is what the normal cell line looks like. So these are monkey kidney cells. So it's an epithelial cell line, and on the right is what it looked like after 2 days with his blood. So diffusely infected cell line. You can see a lot of the cells have died and just dropped off the slide. And those small rounded cells are classic of a herpes simplex. So herpes simplex, I mean, although the background type 1 mainly associated with herpes labialis and type 2 mainly with genital lesions, but worldwide there is a change in the distribution of these viruses. So we're seeing more and more herpes simplex type 1 causing genital infections, for example. And that's, as I say, been described across many countries. The seroprevalence varies across populations. In South Africa, by the time we reach adulthood, most people have been exposed to type 1. So the seroprevalence probably over 90% for type 1, less so for HSV2. We don't have good data in South Africa. In the US, they say around about 30% of adults have been exposed to HSV2. Transmission then by direct contact with mucosal surfaces or damaged skin during close contact. And then the virus establishes latency in the sensory nuclei. It travels there by retrograde axonal movement, and then with reactivation, it returns back to the mucosal surface to cause those classic lesions. But important to remember that you can reactivate asymptomatically and still be shedding the virus. So one can still transmit the virus without having active lesions. Again, just background, we know there's a lot of different clinical pictures. One thing to note is with primary infection in children, it's most commonly a gingival stomatitis, whereas in adults, they tend to present more with a laryngotonsillitis. So a slight difference in the type 1 infections there. So herpes simplex hepatitis specifically was actually only first reported in 1969 in adults. It rarely causes hepatitis in adults, but when it does, because it's part of a disseminated HSV infection, it's usually fulminant and fatal unless treatment is initiated early. So less than 1% of all acute liver failures are caused by herpes simplex virus, and less than 2% of viral acute liver failures are caused by HSV. But the importance, although it's very uncommon, is that it's one of the very few causes for which we do have direct antiviral treatment. So it's really important that we recognize it, although it is rare. It presents mostly in immunosuppressed patients, but it can occur in immunocompetent patients. And it's also not common, but the other group that where it has an important impact is in pregnancy, and particularly in the second and third trimester of pregnancy. So in immunocompromised patients, it can occur due to either recurrent or primary infection, whereas in immunocompetent patients, it's mainly due to primary infection. And the herpes simplex hepatitis cases that are described in the literature are more commonly due to HSV1 than HSV2. So the predisposing conditions are essentially all linked to some kind of defect in cell-mediated immunity. So things like corticosteroids or other immunosuppressive agents, as I said, pregnancy, organ transplantation, malignancies, especially the hematological malignancies. HIV has been described, but actually not commonly associated with herpes simplex hepatitis specifically. There are some descriptions of patients developing herpes simplex hepatitis following inhalational anesthetics, and then autoimmune diseases. So the reasons or the mechanisms by which this can happen are really all hypothetical. There's no evidence at this stage for any of them, but just for interest's sake, there are some hypotheses as to why some people may develop a hepatitis. The one is that there may be a large inoculum at the initial infection, which essentially just overwhelms the immune system, and the infection then disseminates. Probably the most likely is that it disseminates from the mucosal lesions because of the impaired immune response, and they specifically mention macrophages, cytotoxic T cells, so CD8s, and then delayed type hypersensitivity. With reactivation of latent virus, it's been speculated that if one also gets reinfected with another strain, it could lead to enhanced virulence. Again, as I say, there's no real evidence for that. And then lastly, we know that there are some strains that are more prone to being neurovirulent. So it has been hypothesized that there may be similarly petavirulent herpes simplex strains, although from the sequencing that's been done, they've not identified any specific strains that seem to put one at risk. So it's probably more down to patient profile than the actual virus that you're infected with. One of the other hypotheses is that actually HSV dissemination may be more frequent than we think, but potentially not always so severe. And the reason that this has been said is that some studies have shown that in adults with recurrent herpes simplex labialis, actually about 20% of them do have transient positive PCR in peripheral blood with no clinical consequences. And also with genital HSV, about 14% of patients in one study had mildly elevated LFTs with no other signs of dissemination. So we potentially are just not looking closely enough and therefore missing the milder cases. But again, this is a hypothesis, not proven as yet. So clinically, the initial presentation, like with the patient I presented, is very non-specific, so fever and flu-like symptoms, and then progressing to abdominal pain, nausea and vomiting, sometimes hepatomegaly, peritoneal signs. So a number of the cases that are described in the literature have actually ended up having laparotomies for acute abdomens because of the abdominal pain that they present with. So they start off sort of moderately ill for 3 to 10 days, and then see a sudden deterioration with this hepatic necrosis, the develop DS, hypertension, and death usually within about a week. Mucocutaneous lesions described, certainly not in everybody, but in between 18 and 70% of patients. So the absence of mucocutaneous lesions doesn't exclude the diagnosis, but it seems that it might also be down to how carefully one looks for the lesions can explain a lot of those differences. So, for example, in our patient, he described a severe pharyngitis, but at no point did anyone actually look at his throat. So he may well have had mucosal lesions in his throat, which would be a classic primary infection in an adult, actually. So the studies which had the higher rates, like the 70%, for example, is where they actively went and looked for those lesions. I think that's the important thing here, is that it's often not obvious. One has to go and look in the mouth, the pharynx, genital tract, and remember that it can be esophageal as well. So one is generally not going to go and scope the patient like this, but just to be aware that mucosa doesn't necessarily mean that it's easy to find. So the classic triad that we need to be looking for herpes simplex hepatitis is that of fever, leukopenia, and then that marked elevation of serum transaminases. So anything from 100 to 1,000-fold with a relatively slight bilirubin increase. So usually it's an anecteric hepatitis until the patient actually goes into sort of liver failure. So those three things are found almost always in herpes simplex hepatitis, but obviously it gives you a very broad differential diagnosis. But that is the point, is that one wants a wide net and a high index of suspicion. So a lot of the patients who present with a triad are not going to have herpes simplex hepatitis, but if it is there, you need to start empiric therapy so that if it is a herpes simplex, one catches it early. And then one can always obviously stop treatment should you find another diagnosis. They will then classically also then develop thrombocytopenia or coagulopathy with or without HEIC. And then commonly also acute kidney injury, which develops rapidly and then progresses to multi-organ failure, death, such as we saw patients again. The factors that have been associated with a higher mortality, in the literature, there are more cases described in women than in men, but higher fatality rates in men. Age over 40 years, immunocompromised, as I said, is the most common group, but also has a high fatality rate. Obviously, the degree of AST level increase is significant, and then those who develop coagulopathy and encephalopathy also have increased mortality. And the mortality is extremely high. So without antiviral treatment, 80 to 95% of patients will die, even with antiviral treatment, about 70% mortality. And a lot of that, I think, is dependent on how early the treatment is started, so whether it's recognized and started empirically. There's a better prognosis in pregnancy, possibly because of the fact that the degree of immunocompromise is relatively low in pregnancy compared to the other patients. And again, as I said, the mortality very much impacted by when you start treatment and how early you recognize it. So one of the bigger systematic reviews in 52 patients, they only made the correct diagnosis ante-mortem in 23% of patients. So the majority of them were not treated correctly, again, as was our patient. And these were mostly in immunocompromised patients. Although the immunocompetent cases are less common, they're also less often recognized and treated correctly because it's not, people don't have a high index of suspicion. Yeah, so main thing about the diagnosis is obviously to think of it. If we don't look for it, we won't find it. Serology can be useful, but remember that it may be negative early on. And again, we do have that issue with potential for false positive IgMs in patients with severe liver disease, so we do need to do confirmatory testing. So PCR on blood is easy to do, usually quite quickly available, and because it's disseminated, is usually positive in these patients. Liver biopsy is still considered to be the gold standard, but actually it's rarely possible to do it ante-mortem in these patients because they present with a bleeding tendency, so it's really historically of interest. There is immunohistochemical staining available, so these looking for the herpes simplex proteins. And then on histology, we see the classic hemorrhagic necrosis. There's usually minimal signs of infiltration, so not a lot of lymphocyte infiltrates. And then these typical internuclear inclusions, the Cowdrey A bodies, which you can see on the right there, those sort of purple areas with the white rims, and then congestion. So the CTs that are described, there's not a lot of descriptions in the literature, but it's very non-specific, so small diffuse hyperdense dense liver lesions, which just reflects the areas of necrosis, but it unfortunately is very non-specific. So also been well described in other causes of hepatic necrosis like Candida, histoplasma, various other infections, and can look very similar also to sarcoidosis and lymphoma. So CT generally not helpful in terms of diagnosing the herpes simplex, but helpful in excluding other causes. And then lastly, in terms of treatments, obviously supportive therapy, antivirals, specifically with acyclovir, and then liver transplantation in these severe cases is often required. So unfortunately, there are no established guidelines for treating herpes simplex hepatitis and no randomized controlled trials because it is so uncommon. We do know that the prognosis is improved with early antiviral treatments. So in the absence of another diagnosis, empiric acyclovir should always be started for fulminant. Certainly if herpetic lesions are present, but even if there are no lesions, if that triad is present, then it is worth starting treatment. So the recommendations are really based on the isolated reports where there have been favorable outcomes, then also based on what we do know about the treatment of neonatal herpes simplex infections and herpes simplex encephalitis. So we want to treat IV, of course, at 10 milligrams per kilogram 8 hourly. The duration differs widely in the literature, but generally at least 2 to 3 weeks. Some people recommend up to 4 weeks, depending on the patient's clinical improvements. And this is safe in pregnancy as well. There are no reports on using valacyclovir or famciclovir. So at this stage, IV acyclovir is the course to go. And there's also really not enough description of de-escalation to valacyclovir in terms of the timing. So one would want to continue with IV treatment for as long as possible. Internationally, there have been some HSV resistance described more in transplant patients in first world countries where they often are using prophylaxis. It's not a big problem for us that we're aware of in South Africa, although the testing isn't widely available. So we should be fine with the IV acyclovir, but if there is concern, so for example, if it is a transplant patient who has had prophylaxis with acyclovir, then cidofovir or foscarnet are effective as well. And then just to touch on, I said during my case study, other causes of hepatitis, so just looking at the viral causes specifically, obviously hepatitis HE needs to be considered. So hepatitis A, probably the most common cause of fulminant hepatitis, followed by B and then C. Hepatitis E, certainly we know that it occurs in South Africa, but not often described. But hepatitis E would be an important differential in pregnant patients, because they tend to have more severe hepatitis E. Some of the other herpes viruses, so varicella, CMV, and EBV, can all cause hepatitis, but typically not these severely increased AST and ALT like we see with herpes simplex. That it sort of stands out as those very high levels are uncommon with the other herpes viruses. Parvo B19 and adeno can cause hepatitis, and adeno can cause disseminated infection, again, particularly in immunocompromised patients. Yellow fever and the other arboviruses, again, not so commonly that you see those severely raised. So Congo fever, for example, was number one in our differential to rule it out, but actually the liver functions that you see in Congo fever is usually sort of maybe 200-300. It very rarely causes those very high AST and ALT. And then much less common, but described in case studies in the literature, would be even human parainfluenza virus, HH3/6, HIV, some of the intros, and even COVID. So there's a number of viruses that can cause hepatitis, although, as I said, most of them are not severe. It's usually a milder hepatitis.
Thank you. Thank you very much. Anyone have a question?
I think in my life, I think I've treated almost about 15 of them. I lost 2. And statistically, patients that present with severe hepatitis B tend to be, all my seronegative patients were all white. For whatever reason, males.
So that's really interesting, because the literature doesn't say that, but anecdotally, it's my experience as well.
Yeah, it's all white males.
And mostly immunocompetent as well.
And I remember immunocompetent. I remember I had discussion, I don't know whether it was Jennifer, with one of my patients, I think 3 years ago, with a 17-year-old. Then they mentioned something about the monocyte, kind of deficiency in your cell line. I remember that time, I was saying, I don't know whether Jennifer or somebody from Empire. I haven't revisited that again, but it looked like they had certain kind of deficiency, genetic deficiency, they're kind of to do monocyte or lymphocyte kind of deficiency. That's more make them more susceptible to that severe disease, because obviously not everybody. So we managed to pull out about few of them, and one was, I remember, was hepatitis B. That was also, I remember, herpes, that he actually had affairs with his neighbor. And then he presented with hepatitis B, and then of course A, and then I always pick it up earlier, start on treatment, and he went intubation, everything. Then the wife started this Facebook page, like updating everywhere. So when I got the diagnosis, I found hepatitis, herpes simplex 2. And then guess what she put up in the Facebook? And then someone said, but isn't that sexual transmitted? So anyway, I transferred to Donna Gordon. He was in Donna Gordon. Then he came back. And then he had to confess. I remember him very well. So you see quite a lot of these cases. And I think you're right. There's no way for diagnosis hepatitis